Well, thank you very much for inviting me. It's a great honour to speak at a forum like this, which honours the legacy of such an admirable man as Brian Pridmore. Now, I've come up with this slightly PC title. I thought later reproductive years might be a bit more acceptable than advanced maternal age. But I have to say at this stage that things aren't looking too good for tomorrow, are they? She's been to see Kelton, and he's told her she's left it way too late. And she's been to see Erin, and despite doing that, her hypertension's out of control, and she looks like she's developed some superimposed preeclampsia now. And someone has made the brave decision for induction of labour. I see that's been made already. And we'll talk a little bit about that in a moment. Now, I'll just take a step back away from Tamara for a moment and talk about South Australian women in general, to say that we've had a lot of data given to us this evening which confirms the very thing you would see if you sit in an antenatal clinic. We're living in an age of profound demographic change in our obstetric population. Amy showed you right at the start of the forum today how what a rise there is in women of older age giving birth, and particularly having first birth in South Australia. And that is a big change. But I think the other change that we do see, pretty obvious to everybody, is the obesity in our population. It can't be ignored. You can't help but notice generations of families coming in with obesity. And the sad thing is, and we all unfortunately learn this, that age and obesity go together. And as we get older, we all tend to get heavier as well. So we've got a double whammy now in demographic change, and that is we've got increasing maternal age, particularly women having their first baby, and secondly, we've got increasing maternal obesity. And I'd like to show you some data that will give you some idea about the effect of these, and I believe that these effects are cumulative as well. So you might have one, you might have another, or you might have both, and the worst combination would be to have both. Now, our patient Tamara here certainly has the age, and she's overweight without being obese. I think you said her BMI was 27, something like that. The other big change in our obstetric world is the increase in the rate of caesarean section. And in South Australia, we have one of the highest caesarean section rates in the country. We also have, by the way, I might say, one of the highest rates in the country of women over the age of 35 giving birth. And some of the data I'd like to show you in a moment will put those two things together and give you a bit of an explanation as to what's cause and what's effect. So let's start with a bit of data. Now, first of all, I'd like to give you a simple message to take home, and my message to take home, and I'm going to try and prove it to you as I go through, is that the rise in caesarean sections in South Australia is principally due to demographic change, and not to greed of the obstetricians, not to the inconvenience of the obstetrician not wishing to be taken out of bed in the middle of the night or away from the golf course, as is the belief, I think, of a section of the community. But I'd like to show you that it's due principally to demographic change. And the physiological background to this is that data is now available to confirm that the reduced ability to have a vaginal birth with advanced age or later reproductive years, or in fact, if you are obese as well, is due to a decline in myometrial contractility that occurs with age and occurs with increasing BMI. So there's a clear-cut physiological change. Now, there is some change. These now are data from South Australia, from our wonderful South Australian Pregnancy Outcome Unit, and I've been using principally the data from 2013, which is provisional and not yet released, but I've been given this with permission from Wendy Schiller. Now, there is a rise in elective caesarean section. These are women having their first birth, and as you get older, there is a greater rate of elective caesarean section. But when I looked at this, I thought that's probably still a surprisingly low rate of elective caesarean section at 16% for women over the age of 35. I might have thought it would be greater than that. But certainly there is a rise in that. Now, the rest of my data, I'm going to exclude these women who've had an elective caesarean and talk about how women perform in terms of labour, because that's my interest. And this is what happened in South Australia in 2013 if you were aged 35 or greater and you were having your first labour. These are women who had a labour, right? Now, 4 out of 10 would end up having a caesarean section. About 24% will have an instrumental vaginal birth, and only about 1 in 3 of women over the age of 35 will actually have a normal vaginal birth. That's over the age of 35. We're not talking about tomorrow's age of 47. About 1 in 3 over the age of 35 will end up having a normal vaginal birth. How does this compare with younger women? Okay, here it is broken down by age groups. So here's age down this column here, 18 to 29, 30 to 34, 35 plus. If you're 18 to 29, your chance of having an emergency caesarean in your labour is 27%. But if you're over 35, as I said, it's 40%. If you're 18 to 29, your chance of having a normal birth is about 50-50, 1 in 2, and 50-50? Yeah, 1 in 2. And if you're greater than 35, as I said, about a 1 in 3 chance of achieving a normal vaginal birth. So there is a change with age. It's not just that everybody's having caesareans. There's a clear-cut change with age, and it's not a matter of falling off the cliff when you become 35. These changes are incremental from our optimal childbirth age, which is somewhere less than 25, to, and as the years go by, until your fertility peters out completely. So there's not a point at which suddenly you're not going to be able to have a vaginal birth. It's incremental. Your risk is incremental as it goes along. You've heard from Amy about women over 35 and how the numbers of women in that group having their first baby have gone up. By my calculation, it was about 8% in 1999 in South Australia and about approximately 12% in 2013, so the numbers are going up. So research workers internationally have been looking at this rise in caesarean section and trying to see what it is behind it. And there's a group who they did this print. They started in Scotland. As Gordon Smith moved down to Cambridge, he finished the work in Cambridge. But they did a very nice study, and they've been very interested in maternal age. They did a very nice study where they corrected. They looked at caesarean sections in labour, women having their first labour, and they corrected for every known confounding factor that they had, maternal illness, and any other factor you can think of, and they were able to attribute 38% of the rise in primary caesareans from 1980 to 2005 in Scotland as to be attributable to a rise in maternal age. And this at the time when this came out in 2008 was quite groundbreaking. And they're doing some other physiological research, which I'll show you in a moment. Simultaneously, by the way, there was a group in Liverpool who were doing very similar work, but dealing with obesity. So they were looking at the effect of obesity on birth outcomes. Smith has been looking at the effect of age on birth outcomes. So a group of us got together, and several of the people involved in this publication are here in the room, and also Steve Robson from ANU, and we looked at the South Australian Pregnancy Outcome Unit data and did the same experiment using the SA Pregnancy Outcome Unit data. What they did have there is data on BMI, which we didn't have for our study at that time. There's better data available now on BMI, but for those years in South Australia, it was either not collected or not very well collected BMI data. It's being done better now. Our conclusion, doing the same experiment here in South Australia, was that 75% of the rise in primary caesareans in labour from 1991 to 2009 were attributable to a rise in maternal age. So I think we've got pretty good evidence that this isn't the golf course phenomenon. It's actually something to do with a change in the demographics of the population that we're dealing with. Now, to back this up, there's some terrific physiological data. Now, the group in Scotland, and now in Cambridge, have been taking, with permission of course, pieces of myometrium from women at caesarean section and conducting experiments on these strips of myometrium to see how well they contract. And what they've shown here, and this is looking at actually the strength of the contractions, as age goes up, the strength of the contractions in these pieces of myometrium that they could induce went down, quite significantly down. And furthermore, this graph on this side looks at under 30, 30 to 35, greater than 35, looks at abnormal contractions, coupled contractions, and the rate of abnormal contractions goes up dramatically as age goes on. So this lovely experiment shows that there's a physiological basis for the fact that women perform less well, if I can say, use perform is a bit of an awful word, isn't it? If someone could think of a better one, but outcomes of labour are different as you get older and inferior as you get older. And if I may, I know we're talking about age, but the obesity side goes with age, so I guess I'm entitled to do this. Look at these wonderful experiments done in the Liverpool group looking at uterine contractility by BMI. So they look at the contractions here: underweight, normal weight, overweight, and obese. Going like mad like this. Here we are in the underweight. Lovely looking contractions just as we like. In the normal weight, pretty infrequent in the overweight, and it's pretty hard to drum one up at all in the obese. And that's confirmed by these graphs here, looking at amplitude of contractions and frequency of contractions they can induce: underweight, normal weight, overweight, and obese. So I think from these experiments that have been conducted, you'd have to say that there is something intrinsically different about the uterus of a woman who is over 35 and how it behaves in labour from the uterus of a woman who is younger. And so the old clock is definitely ticking, as has been the pretty strong message today. So just to drum it home to you again, that's the message I want to say: the physiological basis for reduced vaginal births with advanced age and obesities is because myometrial contractility decreases with age and BMI. Okay, so let's go back to Tamara. Now, Tamara doesn't quite fit the data I've been presenting because she has had a baby before, although it was quite some years ago. The strongest, if you've had a baby before, the strongest determinant of the outcome of what your birth is going to be in the next birth is what your birth was in the first birth. And principally, that's the influence of having a caesarean section in your first birth. That's the biggest driver of birth outcomes in subsequent births, if you've had a caesarean in your first birth. So she had a normal vaginal birth, but a long time ago. So her uterus is still going to be suffering the effects that we've talked about the declining myometrial contraction with advancing maternal age, and she certainly is advanced in the maternal age. I can't give you figures in South Australia for the birth outcome of a woman of 47 that would be of any meaning, because the numbers are so small as to not be able to have any meaning attached to them. I've dared to provide you the data for women over 40, and I think the number here was about 28 or something, quite small numbers of women over the age of 40 in South Australia in 2013. But of that 28, half of them, this is over 40, half of them ended up with a caesarean in labour, and only about 3 out of 10 achieved a normal vaginal birth. So if you ask me what advice would I be giving Tamara when she was found to have the uncontrolled hypertension superimposed preeclampsia at the age of 47, having her first baby, I think what I would want to do with her would be to make sure that she was fully informed about what she was getting into. And because I think it's up to her to attribute the utility, as they say, or the how much meaning it has to her to achieve a vaginal birth or not. And I don't think that's a decision I can make about how important a vaginal birth, a normal vaginal birth, is to her. But I think that she really ought to know that if she does attempt a labour in this pregnancy, that the likelihood that she's going to achieve a vaginal birth is probably going to be at best about 1 in 4, And the likelihood she's going to have a caesarean section is probably going to be at least 50%, that she'll end up with a caesarean section in labour. And I think it's quite reasonable to inform her of that information and let her make her own decision about whether or not she would, the normal vaginal birth would be so important to her as to go for that, what I would consider to be a relatively small chance. She might consider that to be a very acceptable chance at say about 25%. So that's the way I'd be dealing with her. So thank you very much for listening to me.